Okay, so this section on cardiac disease, talking about the markers, the cardiac markers, and the enzymes, is actually going to be pretty quick. There's only 15 slides. This is going to be a pretty quick review. We're just hitting the key highlights here, things that are going to be of value to you to kind of catch on to when you're doing, when you're looking at paperwork, doing those interfacility transfers. So let's check this out. We're going to talk about the 5 most frequently used cardiac markers, and we're going to detail the timing of the cardiac marker elevations after an MI should occur. And so with our cardiac disease, the cardiac cells become damaged as a result of the hypoxia. And when they do that, they start leaking enzymes. Now, there are 6 commonly encountered cardiac enzymes, and these include CK, creatinine kinase. There is CKMB. There is a lactate dehydrogenase, LDH, myoglobin, troponin, and then a B natriuretic peptide, or BNP. And we're going to look at these. So with the creatinine kinase, or the CK, normal values for men should be somewhere 60 to 100. Women should be 40 to 150. Now there are 3 types of creatinine kinase out there. You have CK1 or CKBB, then you have CKMB, and you also have CKMM. So when they do a creatinine kinase marker, they have to be very specific on what they're looking at, because CKBB is specific for brain, that is 0 to 1%. CKMB is actually your cardiac marker, so we want to look at the cardiac marker in particular. So CKMB is the one we want to look at, should be less than 3%. And then you have one called CKMM, and this is your skeletal muscles. So somewhere between 95 to 100% for CKMM. Now your high levels can be the result of muscle disease or exercise. Anytime where we start damaging muscle, you're going to have some of those, that creatinine kinase is going to leak into the bloodstream and be, removed. But we include muscle disease here, exercise. IM injections can also cause enough damage to trigger this. Cases of shock and tumors, and if they have low levels, there's really no significance here. With CKMB, and remember that's the one we're looking at specifically for the heart, the male and female normal levels, if it's less than 10 units per liter, the MI is improbable. If it gets 10 to 12, it's inconclusive, and if it's over 12, they say that an MI is probable, and high levels indicate myocardial damage. So your CKMB or the creatinine kinase, is the first enzyme to actually elevate after an MI. It is typically increased in about 90% of MIs that are out there, and here's your window of time. So it begins to rise within the first 4 to 6 hours. It peaks at 24, but look at it, it returns to normal within 3 to 4 days. So if you have those patients that keep putting it off because they think they have indigestion, you could be missing this window and not pick up the CKMB, which is why we look at other markers besides just the one. We don't put all our eggs in one basket. We look at all of them. Now, your cardiac markers, your LDH is found in heart, skeletal muscle, your liver, erythrocytes, kidneys, tumors. It increases in about 90% of MIs, but it can be increased in other conditions as noted above. So anytime you have a change or a shift with skeletal muscle or any of those, you can have an increased level as well. So that's why we don't put all our eggs in the one basket. Now, normal range for an adult should be somewhere between 40 to 90 units per liter. Your isoenzymes, just like with the CK, you had different ones. You had CKBB, MB, and MM. And in this case, you have LD1 through LD5. The one that's specific for the heart is LD1. This should be 17 to 27%. Anytime you have a high level, it could be anemias will elevate LDH1 and 2. So those are the ones that we're kind of looking at here. Your pulmonary embolisms will elevate LDH3. Liver damage will go to LDH4 and 5. And then an MI causes reversal of LDH1 and LDH2 ratios. So that's where it kind of shifts. You know, that's one of them. I'm not a huge expert on LDH. I understand the CKMB and the troponin levels. Those are the two key ones for me. This one's a little outside of my knowledge base, so you may want to do some additional research on your own. But with the range, your LDH begins to rise in the first 24 hours, actually peaks in 3 days, and returns to normal in 8 to 9. So if you have that CKMB and you have those levels, you can do comparisons because you know that within 3 days, that CKMB is starting to exit the system. This will peak at that level. Now, your myoglobin is found in striated muscle. It contains iron. It stores oxygen, gives it the red color, gives the muscle the red color. So if you have damage to cardiac or skeletal muscle, it's going to release myoglobin into the circulation, just like with everything else we've seen so far. So with myoglobin, a normal level should be somewhere between 50 to 100. I feel like that was a typo on my part, so I'm not even going to, I think that's supposed to be milliequivalent per deciliter, but yeah, I think that's supposed to be milliequivalent per deciliter. I may be wrong there. Again, this one's not my forte. But your high levels are seen in myocardial necrosis. Low levels are not significant. Your myoglobin will rise about 2 hours after an MI, so it's pretty quick. It peaks at 6 to 8 hours and returns to normal. Look how quick it returns to normal, within 20 to 36 hours. But just like in other cases, you can have false positives if you have someone who has a skeletal muscle injury. So if you've had a marathon runner and they're complaining of chest pain, you could see a false positive on this as a result of the skeletal muscle damage that's taken place from the marathon. Now then you have troponin, and troponin is part of that skeletal muscle when you get into the cellular level and you start looking at the thick and thin filaments, and these little guys slide past each other. It's how you create the muscle contraction, because those little cells or those little filaments slide past each other. In order for that to happen, you'll have this actin, which is what you see in the picture, these little green balls. To me, they look like pearls, like a string of pearls that's been twisted on itself. So you have the actin, and that actin is kind of bound in place by this wire called tropomyosin. And the tropomyosin is bound to the actin by troponin. And troponin will open up and allow those binding sites and allow that filament to slide past each other. So anyway, what you're coming down to is troponin is considered a contractile protein that's involved with the myofibrils. And if you have damage to any type of cardiac muscle, then you're going to release troponin into the bloodstream. Your normal levels of troponin, you can see you have different types here. Troponin I is less than 0.6 nanograms per milliliter. And then if you see cases where it's 1.5 or higher, then you're starting to worry about an MI. With troponin T, your levels that are higher than 0.1 to 0.2 nanograms per milliliter also are indicative of an MI. So that just tells you you do have tissue death. Myocardial necrosis has definitely occurred. There's no significance with low levels. Now, while we like to utilize troponin alongside all the others, it will also rise about 4 to 6 hours after the injury. It peaks at 12 to 16, but if you look at the total here, it stays elevated up to 10 days later. So that's how we are able to use that alongside our others to try to make some sort of diagnosis, or the physicians do, we don't. But it gives us an idea of what's going on. And then finally, we have the cardiac marker BNP. That's B-natriuretic peptide hormone. This is actually something that's found in the ventricles. And when your levels increase, your levels of BNP will increase in the bloodstream as your ventricular filling pressures are too high. So if you have someone who has congestive heart failure and they have that enlarged heart, then you've got BNP that's floating through the bloodstream. Normal should be 5 to 100. High levels indicate abnormal ventricular function or congestive heart failure, and there's low levels are of no significance. And this concludes the section on cardiac markers.